It's good. I think time is up. I would like to introduce today our presenter, Dr. Lay-Hooi Lim. Good morning and good evenings. I am Dr. P.Y. Cho, and my colleagues, Dr. Junior Tu. We both will moderate this webinar. Welcome to ICC webinar today. Dr. Lay-Hooi Lim is a consultant plastics and reconstructive surgeon currently based in Penang, Malaysia. After graduating from University of Malaysia Medical School in 1984, she commenced her surgical training in general surgery in Malaysia, following which she passed her FRCS examination in Edinburgh in 1988, and she went on to train in plastic and reconstructive surgery in Adelaide and Sydney, qualifying in 1993 with the FRACS, plastic and reconstructive surgery, then worked in the UK before returning to her native Penang in 1995 to set up the first resident plastic surgery service at the Penang General Hospital, and which he headed until 2020. Service requirement in a tertiary regional hospital necessitated her to persevere with the practice of plastic surgery across a broad spectrum, including burns, genetic plastic surgery, CMF, head and neck, hands, and more, in order to fulfill the reconstructive needs of the patient population. Her tenure in the Malaysian Ministry of Health also included service as National Head of Plastic Surgery from 2005 to 2014, plus regular contributions at hospital, state, and the national levels in the area of surgical service, training and teaching, and aesthetic medical practice regulations. Involvement in training, teaching, and clinical service remains active and ongoing. Dr. Lim was president for 2 terms of the Malaysian Association of Plastics, Aesthetics, and Craniofacial Surgeon, and the president of the Asian Pacific Craniofacial Association, president of the 8th Congress Asia Pacific Cleft Lip and Palate Craniofacial Anomalies, National Secretary in the Council of the Oriental Society of Aesthetic Plastic Surgeons, and educational board member of AOCMF Asia Pacific. She is grateful for numerous international invitations over the past 2 decades, providing opportunities to share her perspective with and learn from global peers. The most recent of these was in 2023 at the invitation of the Australian Society of Plastic Surgeons as the Sir Benjamin Kerr ranked distinguished visitor at the annual scientific congress of the Royal Australian College of Surgeons in Adelaide, Australia. In her current clinical appointment as consultant PRS at the Gleneagles Penang and honorary consultant at the Penang Hospital, she regards herself as a community plastic and reconstructive surgeon for the population of Penang and the hinterland, continually striving to be a good ambassador for her chosen specialty of plastic surgery. Today, Professor Lim presents the topic of some sort concerning the premaxilla in the bilateral CLP deformity. And today, we are so honored to have 3 our good friend, important panelists to come join the panel discussion. The one is Dr. Gung Chang, and now in Utah, and have several experience in the overseas missions. And the second one is Dr. Dex Carlo Pascasio from Philippines, the alumni of the previous craniofacial fellow in Chang Memorial Hospital. And the last one is Dr. Jordan Stenberg, and the practice in Miami, Florida, and just finished the mission with Dr. Fishers. So can't wait for today. Very, very wonderful and educational presentation. So please, Dr. Lim.
Thank you very much, Professor Chow Bang Yun. It's really my deep honor to be here this evening. So what I'm going to do is to share the screen first. Thank you so much for putting this all together, and the fellow panelists and Professor Low for being here as well. I'm sure you have better ways to spend a Sunday than to listen to me, but anyway, I'll try my best. So ask the compulsory question. Can everyone see my screen?
Yes.
Are we okay? So I will, Yun, you will tell me if there's a problem. I'm going to go on slideshow. I can't see anyone now except my own slides. Everything
good.
okay? That's good? All right.
It's good, yes.
Yeah. So thank you again for this opportunity. It's indeed a deep honor, very special privilege. And it's just going to be like some thoughts, which will probably be raising more questions than giving answers. But first, before I begin, I would like to acknowledge my ties and relationship with from Dr. Nordorf to Professor Ray Chen to Professor Lun Lo, and then now it's a great privilege to be in touch with the next generation. And for my relationship, what you see here is also the orthodontist that I worked with for several years, and both of us have had the opportunity to learn and be encouraged and share ideas with at the Chang Forum. I always regard myself as a repeat student that never graduates, and I keep going back for more learning. But seriously, there has been very great impact on my personal progress as a surgeon. Now, so the topic about the premaxilla in the bilateral cleft lip and palate deformity, the first thing I'm going to disclose is that much of my talk this evening will have its broad framework, which essentially is drawn from this book. And I'm the proud owner of what I consider it to be a real treasure trove of a diary and wonderful illustrations as well. So again, then to quote from this volume 2, to focus then on the problem of the premaxilla, as Milad states it, is that, you know, the presence of the projecting premaxilla and how it is to be handled has always been and continues to be a difficult variable and at the core of some of the controversies. Now, this was written in 1977, and much of it still remains true today. And I look forward to exciting and stimulating discussion with the host and the panelists afterwards. And he also emphasized that in bilateral cleft, that the position of the premaxilla is the keystone to the reconstruction. So the problems, as we know, are functional and aesthetic. It obviously prevents tension-free lip repair in the bilateral cleft. And it goes on to prevent leveling and alignment of the maxillary segments, and therefore can compromise the success of secondary alveolar bone grafting and final dental rehabilitation. And there is malposition in all directions. So it's really a no-brainer to see that it's functional as well as aesthetic in deformities such as this. Now, some fundamental thoughts which I believe are necessary in consideration of a topic like this. I definitely don't claim to be an expert, but drawing on again what is sort of standard embryology pictures in the, at week 6 and week 8 and the formation of a face. And then going on to the area that we're going to focus on, the premaxilla and the prominences that we are familiar with. So, and in the normal situation, there will be the premaxilla bearing the 4 incisors and the boundaries that are drawn here and seen here quite clearly, showing the separation from the primary and the secondary palate. And then these are lovely pictures from the latest Nelligan edition that shows the prominences and the origin of how the central face forms, the ones that we already know about, frontonasal, lateral nasal, maxillary prominences, and the fusion. And to quote from that chapter, basically, for the face to form is a seamless unification of the prominences that is achieved in 2 integrated steps of adhesion and fusion. And as the prominences touch, the ectoderm enveloping each prominence must then get out of a way to create a unified facial structure. And therefore, disruptions in the extent of growth of each facial prominence or the process of fusion can then result in facial clefting. And so to look at it simply, it's if the processes and the prominences have somehow touched, and this is almost like an intrauterine lip adhesion that did not completely fuse, or it maybe could have touched on one side and getting an asymmetric cleft that's incomplete on one side and then complete on the other, or if it didn't touch on both sides and leading then to a bilateral cleft deformity. And therefore, depending on whether they touched and fused or adhered, then leading to various levels of protrusion and projection, and whether that premaxilla is fly away, as has been described by some, without restraint by the lateral prominences. So you can see that with antenatal imaging, I'm not sure whether this is moving on your screen, but if it doesn't, anyway, imagine that it is, but this is a bilateral cleft lip and palate baby yawning away. And I'm just going to move on. And I'm just going to make some mention out of another look at embryology. And it's simply because just over 20 years ago, I had the privilege of sharing the platform at the World IPRIS Congress with Michael Carstens. And he had an interesting way of looking at the embryology from developmental fields and applying it to his functional matrix cleft repair. It's heavy going, his reading, but it's sort of viewing the different areas, almost like neuroangiosomes, and trying to fuse it all together. And to quote him, in reference to blood supply to the premaxilla, he talks about how nature never makes a structure without providing a blood supply to ensure its survival, which brings me on to the next fundamental thought about the premaxilla. And still what remains most relevant, although it is so old, PRS 1960, is the work by Slaughter on the blood vessel patterns in the bilateral cleft lip. And these are diagrams produced from his paper. That's essentially what it tells us is that when the prominences don't fuse, then what's happening right in the middle are basically end arteries. So we see here the terminal branch of the inferior ethmoidal, the posterior septal artery, and there are no anastomosis between that in the middle and those on the lateral side. So bear this in mind when we talk about the technical details later. And then, of course, there's this thing about growth, which is definitely not an unfamiliar subject to this audience for sure, because we're talking about the growth of the craniofacial skeleton and timing of surgery, which is absolutely important and relevant to us. So when it comes to growth in the subject of the premaxilla, we have to look at the midface as a broad base and the nasal septum, and then the vomer premaxillary suture as a growth center, the VPS. And I will make reference then to Paul Manson and to Fresney's chapter in McCarthy's volume. This is like a much older book already, but you will see reproductions of these different size skulls from baby to adulthood. And then an even older version of the McCarthy multi-volume book is the Converse book, and this is what we see from pediatric facial trauma, much of which is still something we need to bear in mind and remember, and is still true and relevant in our practice today. And therefore, in the mid phase, to bear in mind about growth, being anything from 5 to the teenage years, and therefore there are still ongoing forces. And then another useful picture from Paul Manson's chapter, and that's looking at the dentition from at the 3-year-old and the 7-year-old skulls. And again, bear this in mind when we look at the how it plays a part in our surgical considerations. So as Hall and Precious put it together very accurately and easy to visualize, is that during growth, what happens is that the normal maxilla migrates in a forward direction. And then there's an anterior rotation, a vertical elongation, as well as a transverse expansion. And albeit that if there is no cleft and it's an intact craniofacial skeleton, then there are relationships between neighboring bones of the cranium and the face. And the principal agents of these movements are our occlusal forces, the tongue pressure, and the pushing of the nasal septal cartilage. And it's very nicely termed by Hall and Precious. And the nasal septum is called the pacemaker for midfacial growth. So we need to bear that in mind, and that it continues to have a direct effect on premaxillary growth and an indirect effect on maxillary growth. And other authors are in agreement whether before that or after that, the anterior component of the chondrocranium as an anterior component, the nasal septal cartilage is thought to act as a key growth center. Then there is the suture, the vomeral premaxillary suture in children. That's very well described and looked at by in this paper. And the relevance of it is that traumatic interference is likely to impair growth and therefore can potentially lead to midface retrusion. And this is with relevance to the cleft lip and palate. So these are the fundamental thoughts which influence our clinical approach. And at this point, I want to go back again to this volume 2 and walk through this algorithm that's in chapter 3 of Milad's volume 2 on bilateral clefts. And essentially, you see that much of it can be reproduced in a modern setting, but remains relevant whether the premaxilla was excised and is no more practiced, or whether there are traction devices, or what he used to call setback procedures, and then there's lip closure. So this will be a sort of a scaffolding in how we look at the subject. But historically, excision was performed in the Middle Ages, and then Kilner did write about it, that if it was wobbly, he would take it off at 5 to 7 years old, and then there was partial secondary excision described by Gillies and Potter. And just to have a graphic description, again, the picture is from Milad's book, and he described it as using this bone holder and forcing the premaxilla backwards, the prominent portion of the jaw, And this attempts to bring the teeth down to their proper level. And he says it's commonly attended to with a slight fracture of the bone. That was in 1844. And then this algorithm also has a portion on extraoral traction, whereby these historical pictures are quite delightful to look at. And then now there are modern appliances which essentially can perform the same thing. But I make special mention because Milad also made special mention of Bill Manchester's device in 1967, which is an intraoral device where he extended a rubber band from within the mouth for the premaxilla. I met Sir William Manchester in the early 90s during one of the trainee conferences in Auckland. And he was certainly a very sprightly and very wonderful individual to have met, for me to have met in those days. He had served in Malaya in the Second World War, so it was quite very interesting listening to him. Now, in this volume as well, of course, the Latham device was mentioned and described. And if you look at the handwritten notes below the child, below the picture of the baby, is that Milad has written there, Nick Georgiade has promised to send me a Mark III, and Berkowitz will be challenged to try it. And certainly he was challenged to try it. I will say no more, except to put it on the screen for younger members of the audience who are probably not aware of this progress made at that time in the 70s. I'm sure there can be more talk about that. So back to the algorithm, I want to now focus on this bit about closure of the lip as a method of managing the projecting premaxilla. And at this point in time, I want to then make reference to the technique which I use, which was described by Jim Trott. And I would like to acknowledge here what I call the trinity of bosses in cleft and craniofacial surgery in Adelaide. And Jim Trott was the second person of the trinity. And he described this while I was working in Australia. And at that time, I did not realize that the strategy would have a great impact on how it would help the patients that I was going to treat after coming back. So there are details which can be obtained from the paper itself. And although it was initially pushed as mainly a nasal correction strategy, certainly I see the application much more broadly. And in the subject of tackling the projecting premaxilla, certainly working in situations whereby there's no pre-surgical orthopedics at that time, no NAM, and even later on I could do without strapping. This surgical approach was enough to achieve a strong repair that could withstand the forces that were working against an intact repair. And yet at the same time, there was post-operative molding of the premaxilla to get it to not to match, but probably to position the premaxilla possibly even in a better position than the lateral segments. And but the observation of post-operative molding had already been made earlier. And it was, I quote from this paper, that recession of the protruding premaxilla will occur following lip closure. And this observation and this experience also, I believe, also accounted for the observation that no premaxillary osteotomies were required, as reported by the Oslo group in 79 clefts, and then by the French group more recently, out of 189 bilateral clefts, they only required 3 premaxillar surgical repositioning. In my personal series of the modified trot repair of the bilateral cleft, where there were no ancillary devices or any additional maneuvers in 231 cases, no dehiscences, there was no surgical repositioning of the premaxilla during infancy, but 2 were required at adolescence. So, the point is that it is not something that is frequently or regularly required. Just some examples of the trot repair, which as it was, when it was reported, was usually more about the nose, but it also, as a byproduct, helped to deal with the proceeding premaxilla, so that one could then achieve a reasonable form of dental rehabilitation at maturity. So similar sort of bilateral complete cleft palate, lip and palate, again without any ancillary devices, at 14 years old, and then at 19 years old, without prosthetic devices as well, that was required to replace this is her own dentition, and this is her final profile at 19 years with the help of a ginoplasty and an abbey flap and a rhinoplasty. So I just want to make a little detour, although there was no surgery on the premaxilla, just to illustrate this importance of the blood supply that I talked about earlier. And that is 1 out of the 231 cases, there was ischemia of the premaxilla. And if you look at the picture on the left on the operative day of surgery, you will see a very dusky looking premaxilla. And then the mucosa was lost, and later on the teeth were, the incisors were lost as well. They never emerged. And why did this happen? Just again, just to remind ourselves again of the blood supply. And essentially in the trot repair, I'm not sure if my mouse is showing on your screen, but the maintenance of a continuous, generous strip of septal mucosa on here as well as on the lateral surfaces is very important in maintaining the blood supply, because what happens on the nasal side is that the anterior palate has a single layer closure using reflected nasal septal mucosa from the anterior portion of the midline, uniting with the lateral nasal mucosa. So in that particular case, what happened was that I had been too aggressive and left too narrow a strip. So this is how important the blood supply is. So this is the child. You can see the loss of upper lip support from the loss of teeth, and probably the loss of volume of the bone of the premaxilla as well. So although the nose was maintained, but the onslaught had been absorbed by the skeleton. So I guess to simplify the thought so far in this part about lip closure, handling the projecting premaxilla, is a point that was already made by Millard in the 70s. And he already made the point that osteotomy and ostectomy is seldom indicated. Although various descriptions in the past of doing boomerang osteotomies have been described, and even his peers were already writing about it quite a lot. But he did agree with William Olin from Iowa, who objected to this and saying that these patients who have their premaxilla routinely surgically repositioned, the premaxilla repositioned in infancy, they have a serious mid-third of the face growth problem. And so this continues to be a real source of anxiety whenever we do anything in that area, as in the infancy stage. So to essentially, we can look at maneuvers on the premaxilla from a very simplified point of view. It could be surgical, non-surgical, and the timing can be in these broad groups. If it's non-surgical, it can be dynamic or static, but obviously these have to be achieved over a period of time, but there's less risk of growth disturbance, although it's labor intensive. If it's surgical, if it's achieved well on the operating table, I gather that most of us are surgeons here, and it's something that's immediately effective, but there comes with it the risk of necrosis of the premaxilla, non-union, malposition, whether we put it too far back, and definitely a higher risk of growth disturbances. Now, I'll just mention this in passing, that the non-surgical methods continue to be relevant. And of course, we're looking at NAM, strapping, lip adhesion. We've talked about the lip repair. And I believe later, I'm really looking forward to this. Our panelists and chair put this together with Professor Low, put up this paper on a rescue procedure. So I won't say any more about it, except to give you this little teaser so that you can look forward to it. And of course, Eric Liu's famous device out from Chang, which was modified later by Miazzini. So again, these are non-surgical treatments. So these are possible, but many of us do not have access to this. And so the rest of it, of this presentation, I will talk about the surgical maneuvers on the premaxilla. I just want to highlight two recent publications to the audience, and you can discuss or make up your mind yourselves later. But essentially, one looked at 36 patients of a median age of 8.8 months that had these premaxillary osteotomies, and another one looked at 11 patients of 3 to 14 months. But the follow-up for both were like about 2 to 4 years. So they're early years yet. So the timing basically was objected to when it's early, very early on, as you've already heard. Although and Pruzensky did make a point that whether it's infancy or early childhood, it's still, there's no difference. But others have made a note that if it's at about 10 years of age, then the outcomes are significantly better. I just want to step out for a bit to, that when we look at different writings and thoughts about this, it's called various things. Whether it's a resection, whether it's a setback, whether it's a repositioning or a retropositioning, whether it's an osteotomy or ostectomy or a surgical repositioning. Why is this important? Because for a long time, a lot of us were thinking it was mainly a setback. It was in a casual conversation with cord cutting that he made a point that it was more a vertical repositioning rather than a setback. And the osteotomy basically just describes that there's an osteotomy. So, but whatever it is, whatever we call it, I now prefer to call it a surgical repositioning of the premaxilla. The aim is to achieve a stable, viable premaxilla that is aligned and level with the maxillary arteries, as to how far back we push it, that's again something which we can talk about. And definitely we've got to factor all of this, which you've already heard about earlier. And this is 2 out of the 261 cases that I mentioned earlier, which required the premaxillary surgical repositioning. So this is her without any, she was like lost to follow-up, then she turned up, and so this is where I have to escape to show the movements. Is it playing, Pang Yun?
Yes, it's good.
Okay.
Yeah.
So if you see it, yeah, it's that vertical push up that rather than pushing it back, which is something which I found useful to remember. But of course, the vectors are more than that. So this is the same patient. And then at 15 years old, she gets an Abbey flap. And this is her at 20 years old as an adult. So I'm just going to race through this, but basically at a time when I thought that, I combined it at this time staged her with an alveolar bone graft as well on one side, and then did the alveolar bone graft on the other side. And at a time when I thought that I figured it all by myself, then I found out that a whole number of others had already talked about the case and how to tackle it, and doing staged alveolar bone grafts at the time of repositioning. So I'll just race through this. And this is another one as well, having had a trot repair. And this is her at 8 years old. And the orthodontist requested that, to intrude it could possibly end up with a resorption of the roots. So we went on then to plan for a repositioning, a surgical repositioning, and the considerations were then to avoid the tooth germs. So what I did was to do the osteotomy. This one I did it in front of the VPS, did a vertical repositioning, a highly located mini plate to avoid the along the piriform margin. It's kind of semi-rigid, and then the cancellous bone graft on this side at the time of surgical, at the time of osteotomy, and then stage the other side ABG to another instance. And so this is her after the leveling surgically and maintained by the orthodontist, which is arch wire. And this is her at 18 years old. Of course, we can improve her further, but that's the subject for another day. So a couple of cases to finish off. These are where the lip and palate repairs that have been done elsewhere, and just using them to make some technical considerations. So here we have a descended premaxilla, vertical access has been described at 9 years old. And so when we look at something like this laterally, the profile is to bear in mind a diagram in our minds and the structure that we have to deal with. And in this case, I use incisions, using this along these red lines. It's quite hard to draw because there's another incision that will extend into the lateral mucogingival advancement flap to create that pocket to house the bone graft. But the point I want to make is that the vector of the movement is like to use an oblique osteotomy, it helps to be able to do that counterclockwise rotation. So rather than to resect bone at one go, it's just to do the osteotomy first and then to burr away bony interferences or protrusion. And of course, with that vertical movement and a bit of that rotation, the septal cartilage will have to be resected according to its interference with the mobilized and repositioned premaxilla. So you see the blue line here that marks that oblique osteotomy. And then there's an ABG to the right side that's on top of that, that's done later. But the difference between the top and the bottom picture you will see is the level of the premaxilla in relation to the lateral arches. And a small little mini plate as high as possible, a tiny little plate, just to help to hold it, as well as some interdental wiring. Another case, this one was unique because the bone graft had already been done on one side, and the premaxilla continues to be displaced and descended caudate and inferiorly. In this situation, what I found is that it was a very successful alveolar bone graft on the opposite side, so much so that it wasn't just a premaxillary osteotomy. There was an alveolar bone graft osteotomy that had to be added in order to reposition the maxilla before I could then graft the do an alveolar bone graft on the right side. So it's a surrogate result. It's not great, but I managed to achieve fistular closure on the site which I had done the premaxillary osteotomy. But the original site, which already had the bone graft done, I couldn't get that fistula closed. So this is it. So in summary, some of my current thoughts concerning the premaxilla and the surgical repositioning is that I would personally prefer to avoid it in infancy. In the patient population that has come under my watch, I find that it's infrequently needed. And if it's needed, I prefer to stage it, time it at the phase of mixed dentition. Then when the permanent incisors are already stable and erupted, I prefer to stage it in terms of bone grafting the side of the one side where I approach to do the osteotomy for purposes of blood supply to the premaxilla as well, and then the bone graft to the other side. All this to achieve continuity of the upper dental arch, and it is very likely that it is an interim procedure that will need definitive facial osteotomies. And with that, I'd like to say thank you very much for panelists from across the world and different time zones, and this is where I am. That's where Southeast Asia and Penang. Here you see Sumatra and Malaysia, and I'm somewhere where the red dot is right now. Thank you.
Thank you so much, Dr. Lim, for the very thorough and informative presentation. Now, Dr. Lim, you mentioned about a paper that was written by Professor Low and his group. So actually, one of the authors is KC, and I was wondering if KC can share that paper with us, just for discussion. Hey, KC, are you there? I don't know if Casey is there right now.
Yeah, I'm here.
Yes, yes.
Oh, okay.
Yes.
Great. Casey, would you mind telling us a little bit about the paper that you wrote as a first author, an intraoperative rescue procedure for the protruding premaxilla in the repair of complete bilateral cleft lip?
So basically, I mean, most of surgeons been trying. Sometimes we just make joke about the technique, that's just thumb technique, but we made a terminology about RPM, or rapid premaxillary molding, which is pretty much I think it's limited up to the 8 months of age, because past the 8 to 9 months we cannot actually mobilize the premaxilla. So I think the Professor Law and our co-authors, we thought about how can we describe this technique. I mean, there is still Dr. I forgot criticize about our method, but I think the most of the surgeon has been practicing same method, aka thumb technique. So basically what we've been doing is basically we are not fracturing premaxilla, because it's the bomber or premaxillary suture is still flexible. So we are just like gently pressing the premaxilla with the elasticity or flexibility. So we can not actually fracturing, just like repositioning, but this one is still, I think we have a video clip as well in that publication. You can see it is still flexible. The premaxilla is flexible, and then we repair the muscle repair, make sure that we have a good muscle dissection, and then fully cover it so we can resist the tension as well. I think that's basically the main core description of the paper.
Okay, Professor Low, is there anything that you would like to add for the paper?
Yeah, that's because if the baby is still young enough, for example, 8 months or younger, the premaxilla is still quite elastic. So we can do under general anesthesia, we can do a gentle massage. We call it molding. This is, you have to control the force using your finger, not to push too much, not to fracture the premaxilla, but you actually can feel that the premaxilla is coming gradually backward. Then at the same time, I dissect the muscle. The muscle dissection should be quite extensive because we rely on muscle to repair and then to further push back the premaxilla. And then you actually, during the two to 3 hours of surgery, you can do rapid molding several times, and you can feel gradually it will move. And then I do muscle suture just to be ready, and then push the premaxilla backward, and then shoot and close, and then tighten the muscle suture. So this is basically for a younger baby. For the older baby, I don't think that it will work well.
Okay, thank you, Professor Low. So now we'll head back to our panel discussion. So first, I'd like to invite Casey once again. Casey, do you have any comments or questions for Dr. Lim?
Dr. Lim, what's the age that, so you didn't, you don't repair bilateral cleft lip with the protruding premaxilla, right? If I just understand correctly, or do you repair?
I repair the lip.
Okay.
Yeah, and as would be usual, and the anterior palate, and perform an open rhinoplasty at the same time. And then 6 months later, I repair the secondary palate and unite the repair with the anterior palate achieved from the first repair. Yes, I do. So when I say I don't, what I meant was that I don't do anything to the premaxilla per se.
I see.
So no devices, no no nasal molding, and it's entirely dependent on the lip nose anterior palate repair.
So you don't any finger manipulation or any osteotomy, just straight repair.
It's all dependent on the subperiosteal dissection and the movement of the lateral soft tissue elements, especially the muscle, to get a secure union right over the premaxilla, and to position it such that it doesn't slide too high up onto the anterior nasal spine. And then with that, it achieves the post-operative molding of the premaxilla.
I see. The reason is that I have to be honest myself. I already have two complications that the premaxilla just rebounds back, and then the lip repair, even though I did the extensive muscle dissection. And then, you know, whatever, there is many factors. Number one, malnutrition and then all that. And then, but you never had any problem to close bilateral cleft lip without any complication after, without any kind of manipulation of premaxilla. That's because you have many years of experience. I feel like you may have some, because my colleague at the mission field, I went back and then I saw there is complication without any I think it's more likely, sorry for my short, just passing through other stories, but I think it depends on the severity of the premaxillary protrusion. I think if there is I'm not sure, it's maybe mild, moderate, and severe, more than even last week. I consulted for bilateral cleft baby. It's already like more than a centimeter. Actually, I measured it. It's a centimeter and 1.2 centimeter premaxillary protrusion at the, like, just born, newborn baby. So I think I was wondering if I can ever achieve without any kind of manipulation to primarily close bilateral cleft lip. So that's why I think that without any kind of manipulation, maybe it's possible, but I think there is a certain limitation in my personal opinion.
Well, the anxieties are always there, right from the beginning, and I always make it a point to describe to the people who are involved in the surgery that you never know that you're going to get there in front of the premaxilla until you actually get there. So the maneuvers are several. Some of it's all at the subperiosteal plane. That's one plane of advancement. And then it has to be a very clean, shiny periosteum that we lift up above that baby skeleton. And then sometimes what helps is to do an L-shaped release of that periosteum where the lateral maxillary buttress is. That one helps a lot. And then I will put a gauze, like quite a big gauze, and stuff it in there and push and stretch. So there's a intraoperative tissue expansion while I go on to do something else. And at the same time, with the separation of the muscle from the lip mucosa as well as the nasal mucosa, that vector comes in a different direction. So the release from the piriform margin in what is obviously a very receded lateral shelf, receded lateral segment, that release is critical. And that is where I found that the use of the Nordorf inferior turbinate flap. Dr. Nordorf used to use the inferior turbinate flap in a different way, but I repurposed it and used it as part of the release from the maxillary segments. It's a bit, I'm not sure if you're getting me, but the release comes at different levels. So, but yes, certainly it remains challenging. And I'm very sure that it will continue to be a real anxiety, especially out in the mission field, whereby you're not there after the 1 or 2 weeks is over, to ensure that no accidents happen, that the child doesn't fall over or something like that. But I did do one case of a very, very bad protruding premaxilla when Professor Low and I were in Pakistan many years ago, and they left the worst bilateral cleft for me to do, and it did survive the dissection, and I was told that the patient healed up.
So, Professor Lim, so in your professional, your experience, and then your long years of practice, I think without any kind of manipulation, you can primarily close the bilateral protrude premaxilla cleft lip, and it won't be a problem.
I mean, I won't say it won't be. I mean, it's.
I'm just
it's,
kidding. Sorry for
I
my
never say never. The
True.
moment I say never, there will be a problem. But so far, okay.
Okay, thank you.
Thank you.
All right, thank you, Casey. Next, I'd like to invite our next panelist, Dr. Picasso. Dex?
Yes, Junior, thank you. Dr. Lim, thank you for that presentation. Amazing results, by the way, beautiful results. Anyways, I also want to comment, that when Casey and Dr. Lo says there's that gentle push of the thumb, when you get to see us do that, it's not actually that gentle. Actually, it actually applies a lot of force, even though they say it's gentle. Anyways, please oblige me, Dr. Lim. I do have a few questions. First is, I do agree that as much as possible, you seldom need to do a premaxillary, setback, or the one that you use. It's a sliding osteotomy where you actually put it in, more superiorly. But may I ask, what are the indications that you look for? Or do you have arbitrary numbers? Do you measure the premaxilla to the lateral arches, and then when it reaches a certain number, you would say that this might need a procedure later on? And second is that I think that's a good procedure, the one where you slide it upward. My only question is that how do you deal with the torsion? Because there are some premaxilla that are not just protruded, they're actually rotated almost 90 degrees. And I fathom that if you're just going to slide it, you might not have enough area that you can secure it with.
Thank you. So the first one is about how do you anticipate which cases are going to need it? So the ones that it would depend on the orthodontist that I'm partnering with for the cases if they are getting orthodontic treatment. Generally, I'm quite lucky in the sense that the patient population would have access to orthodontic treatment, and it would then depend on how they are able to reposition. I mean, use their appliances to do the magic that they do. So I let them make that decision for me. But usually, if it is like one whole tooth height further down, and they're having trouble, and they're not making much progress, then that would be an indication. But it's not a decision that we make very quickly. Sometimes we take some months, a year or two to decide on that one. So it's a joint decision, and it's not mainly just like measurements. And then we tell the patient that you must. So I tend to wait if I can. The other thing about dealing with torsion is that it would help, as you have seen you would have seen, I'm sure, is that if there is a prepared occlusal stent that can be used to help to stabilize. But quite often it's a feel. Quite often it's having an eyeball movement and then burring where it is clashing, and nibbling and burring a bit at a time, just so that it gets maximum bony contact, as well as a position that matches the arch as best as possible. And yet you don't want it to be so recessed into where the lateral arches are, because sometimes that can make it too recessed, if you get my point.
Yes, I would also like to ask, because when you do that, how do you secure it with the plates? Because it might, I fathom it might be very difficult. The contour might not be enough for, I mean, for the plate to have a secure a bite. So how do you do that? Do you end up just doing a like somewhat like a lag screw going through it, or do you still try to secure it with a plate?
Okay, with great difficulty. With a plate, a tiny plate, especially those old micro Leibinger plates, and they're not strong, obviously, and that's why I say it's semi-rigid. And so the stabilization at the occlusal level, sometimes my orthodontist will prepare a different arch wire ready for me to place intraoperatively after having achieved the movement. So then that arch wire helps to stabilize it at, there's one stabilization at the bony level and another one at the occlusal level. And then the packing of the bone graft and the soft tissue preparation of the flaps on the nasal floor, on the oral side, and then that gingival advancement from the side. That one all helps to stabilize. It's kind of like a GPP, but with bone graft, not those boneless GPP, but making sure that there is good gingival periosteal closure. So those three things add to stability.
So I guess the great lesson here is you have to have a great dental partner for this one.
Yes.
Because of course, in our setting, especially in the provinces here in the Philippines, where we don't get to have dental partners, we end up trying to stabilize the premaxilla by trying to secure it to the lateral arches. Of course, that's a very crude way of doing it. We would still rather have the arch wires. So in your practice, since you have the dentist, you don't secure it on the lateral arches anymore, the premaxilla, because we used to use PDS 2.0 sutures just to take a bite on the premaxilla on both sides and then secure it to the lateral arches just to make sure it helps with especially when you deal with the torsion. So you don't advocate doing that anymore, especially if you have your dentist, correct?
Yes, definitely. If you have the assistance of our dental colleagues, definitely huge help.
Thank you, Dr. Lim.
And thank you too, Dax. So next I'd like to invite Jordan, Dr. Steinberg.
Hi, thanks so much for a great lecture. I think there are so many difficult aspects of this, and for those of us that are doing a lot of international work where we don't always have all the tools, I think it's one of the most difficult problems that we come across. There was a international webinar maybe about 6 months ago on this topic, and one group presented on pre-surgical orthopedic molding. Another group presented on lip adhesions, which I see you've had a couple of questions in the chat from different people about lip adhesions. And then another group presented on premaxillary osteotomies. And I think that what seems to be clear is that there are pluses and minuses to all of the approaches, and there's nothing that comes for free, meaning that even with non-surgical treatment such as orthopedic molding, it often comes at the expense of a very, very big curvature in the vomer and the septum, and potentially occlusion of the nasal airway. Although if you have that option, many would prefer it, but we don't always obviously have that in different centers. And so I think there are many different ways to look at this. If it's a initial repair of the lip, let's say either just going for a definitive repair right away or doing a lip adhesion, the question is, what is it about the technique that you can minimize some of the problems? Because the things that we will see sometimes when a lip repair is let's say forced include fractures, unpredictable fractures of the premaxilla with persistent non-union, premaxillars that sort of erupt through the lip repair, lip repairs that end up riding very high, and the premaxilla is completely herniated below and remains that way for years. So there can be a lot of problems even if the tissues heal. So I wonder if you can comment on that.
So we'll start off with the ones that have healed through the lip repairs, and the first confession is that I've not had much experience in that. When I first came back to Malaysia, essentially what I encountered were dehisced repairs, and then also attempted lip adhesions. Some will like attempt one side and then try and do the other side, and then the first side breaks down, and then it becomes like a yo-yo. Then you end up with more and more scars, and then the ones that protrude and what they call the locked out premaxilla, whereby the lip unites behind it, and then there's this premaxilla in front. So those are the ones whereby, difficult as it is, in my context, the approach would have been to wait for as long as possible until the tissues get stronger and the scars get softer, and then there is like a bigger chance at taking it all down and doing wide mobilization. And the key, I mean, when Jim Trott described that procedure, it also came out of a necessity, because the patients that were presented to him were either secondary cases which had suffered this kind of complications, or again that time the appliances and the pre-surgical movements were just totally unavailable. So therefore the tissue planes of mobilization then was like critical, and the point was to be gentle and yet to be strong. That means that subperiosteal mobilization that goes all the way in these tiny phases and circumnavigates the infraorbital nerve, viewing it at the foramen and going pretty much all the way out to the malar prominences, to the zygoma, but being careful and very purposeful in the subperiosteal and periosteal elevation. That means not plunging into what is essentially a pediatric maxilla, and therefore the bone could be quite soft, and yet at the same time being able to lift up the entire soft tissue envelope. And so for the cases that have already suffered a failed primary repair, my main strategy would be wait, feel, then the pinch test over the face, and if that, the tissues get stronger and can withstand a major surgical assault or maneuver, but it has to be very purposeful. Pretty much no margin for like failing again, because we're dealing with scars and at the edges. Yeah, I mean, no easy answers, I have to say, really no easy answers, but the number of reoperations definitely has to be like kept at as little as possible.
Because I think one of the main questions that would be good for all of us to address is, for those around the world, again, who don't have all the resources, don't have access to any pre-surgical molding, and are wondering what do we do with these patients that have the anatomy like this, and what is the best advice? Let's say if somebody doesn't have all of the expertise with different modifications of the technical parts of the lip repair, but has the average set of tools. And the other thing I wonder about as well is in some cases where, let's say a premaxillary osteotomy is done, but the palate is repaired first rather than the lip. And the reason for that is that, again, there's going to be a lot less dissection and you know, risks as far as ischemia to the premaxilla, but at the same time, you would have to make a vomer incision to do the osteotomy, and you could potentially secure the premaxillary segment, you know, in the process of doing the palate repair. And I'm not sure that that's something that a lot of groups consider, but it could be an option in some cases as well.
Yeah, I totally agree with that. It makes a lot of sense. And especially depending on how old the child is, that when the lip is all open, and not dissecting for the lip repair, and instead saving the blood supply to position the premaxilla first, and then after that coming to do the lip repair. I think it's very sensible. And it makes the patient come back for repair.
Thanks.
Thank you so much, Dr. Steinberg. Next, we are very honored to have a special guest with us today, and it's Dr. Maria Miazzini and then Dr. Miazzini is actually the current European Cleft Palate Craniofacial Association Congress president. So I'd like to invite her for some comments.
Thank you so much for having me. I'm not actually part of the panel. Dr. Lim, I was super impressed by your results, and thank you for mentioning me, actually. And super impressed by your curriculum. My husband was walking beside the table, and I told him, wow, this woman is so tough. She went to Australia and all over the world, and then went back to her country and made lives of so many children better. So I'm truly, truly impressed by what you've done. And the thing that impressed me the most was the idea that you've shown 330 something patients in which you had no orthodontist doing the NAM for you, and you had only one problem. And of course you said, well, let's not look for problems, but it just confirms what I've always thought. If a surgeon is patient and does things with not being too aggressively, can obtain great results even without the help of an orthodontist. And I think what you've just shown is going against this new wave of ostectomies that there's a lot of we're doing a lot of, there are a lot of groups even of my friends that go around the world doing charity missions, and it's beautiful, but a lot of them tend, when they see a premaxilla which is really outwards, to just chuck it back because it's faster, because it seems to be easier, and because there seems to be no other option. But you've shown that there is an option even without NAM. My other comment, if I may, and then I'll be done, is that you've shown a couple of either deciduous or mixed dentition cases where you've done an osteotomy of the premaxilla, and I'm very lucky because I have a beautiful relationship with my surgeon, and when he sees those distances between the lesser segment and premaxilla, he lets me bring forward the lesser segment. So he just has a simple job afterwards with no ostectomy or no osteotomy of the premaxilla. And that has two advantages. One, you never know in terms of growth, and so you're doing nothing in terms of growth. And second, your surgery becomes really simple, and the orthodontics to prepare it is really not difficult for the child. It's just like an 9-month orthodontic simple advancement of the lesser segments so that the surgeon can work easily. And that's it. So I'll stop, I'll shut up. Thank you so much. Your presentation was unbelievable. Thank you.
Thank you very much. I am really honored by your presence. When I went through the papers, I had no idea you were going to be around, so it wasn't like it was orchestrated. Just that I was looking at, and I thought, what a brilliant way of dealing with it. May I ask you a question then about to work on the lateral segments, the lesser segments, what is your pivot, your fulcrum then of advancing it? I mean, this is a simpleton question, it's a naive question. It's probably very complicated, I'm sure, but if you could maybe talk more about that.
Absolutely, it's super simple, and it's not a simpleton question. It's just that we do different jobs, but usually when the child is in deciduous or early mixed dentition, you can still have a lot of effect by using, for example, let's say it's a unilateral. I would be honored to send you the paper that we published about it. When you have a unilateral, huge, let's call it fistula, or east, she's already open. So you close it slowly, and by closing it, the lesser segment is pulled forward till the lesser segments gets closer and closer and closer to the premaxilla. You might wish to use a face mask to help pulling it forward, but it's more the effect of the open expander, which closes slowly. And you can do exactly the same thing in bilaterals. And there, the support is more important. Older children, then you can use a modification of the ultramic technique that was invented by Eric Liu, who's from Taiwan. And you can basically pull the two lesser segments forward by using CADs, which are like screws, long screws, and then elastics, which are worn 24 hours a day, to pull the two lesser segments forward till they're in contact with the premaxilla. So the premaxilla stays where it is, and you pull everything forward towards it. And then your surgeon can put the bone graft without any difficulty.
Actually, that sounds like it makes a lot more logical sense than putting the premaxilla to meet the lateral segments. Because quite often when we do that, then we end up with a more recessed midface in trying to, so that's why, yeah, so it just makes a lot more sense. Yeah, thank you for that.
Thank you so much, Professor Miyazzini. And last but not least, I'd like to invite Professor.
Yeah, hi, Lay-Hooi. It's very nice to hear your talk, and yeah, I would like to talk to tell the audience that bilateral lip repair in the presence of premaxilla protruding is very difficult. I think Dr. Lim did not have complication, I think mainly because of her experience. I think in his presentation, she talked about the extensive dissection, release of tension, good muscle repair. I think this mainly based on a good experience. And I think bilateral lip repair and dehiscence actually is, I always saw this complication in my mission in the neighboring countries. So either you need to learn a good technique, or you need to leave the patient to other more experienced surgeons. This is what I would like to say. In Chang'an, we have very good orthodontic support, so we could repair the lip under less tension. I think this is in this I'm more lucky than Lay-Hooi in Penang. However, if when I do mission in the neighboring country, I will also do my best to free the muscle to dissect the tissue, just to make sure that I can repair under less tension, that I can feel comfortable. Otherwise, you have to be very careful. And for the for the osteotomy, I really do not do much osteotomy or premaxilla repositioning. However, in my experience, I did do some several osteotomy if patients alveolar cleft remain quite big, quite huge, and premaxilla is still protruding much more than the mandible. So in this case, I would do osteotomy. When I do osteotomy repositioning, I always ask my orthodontist to provide occlusal spin. Where is the premaxilla going backward and to meet the two lateral segments? What is the ideal position rather than just to guess during the operation? And so I use the occlusal spin, stabilize the premaxilla segment, and then I will use K-pin to fix the premaxilla, and also make sure that there's a bone contact so that you don't have later on you don't have the mobile premaxilla. So K-pin usually remove the K-pin 6 weeks or roughly 6 weeks later, and then you will have a quite stable premaxilla. And then I will do ABG, alveolar bone graft. I don't like to do the alveolar bone graft simultaneously. I did do GPP, repair the gingival periosteal tissue, because in my experience, simultaneous bone graft very often have infection. So this is my experience. And when patient achieve adult skeletally mature, then I will see the patient. If I really had to do the 4-1 with 3 segments, because the premaxilla segment, the blood supply and the movement is quite limited. So I try to avoid that. So before the OGS, orthodontic surgery, I would try to do at least one side bone graft. So I would turn the 3 segments into 2 segments, that it would be easier to close the 2 segments. If I see the premaxilla is in ideal position, and I will move the 2 lateral segments in the orthodontic surgery, 2 lateral segments forward to meet the premaxilla, and then do gingival periosteoplasty, and that also was occasionally occur in my practice. So this is roughly my experience. And by the way, in the growing age, if sometimes alveolar cleft is still very wide in one side, I may consider to do tongue flap to close the gap. And later on, I will do the alveolar bone graft to make it the bimaxilla bilateral cleft into one piece. So in the future, when I do the 4-1, it's easier to perform the 4-1. So this is the experience.
Can I ask you how you do you fix the premaxilla during osteotomy, or do you totally rely on the occlusal stent, the wafer that has been fabricated before surgery?
You mean the
premaxilla
setback using K-pin, and I will still remain the occlusal spring. This is only one side to the maxilla, and I will wire. Certainly, my orthodontist will put some brackets so I can wire the occlusal spring to the upper teeth, so just to immobilize, and plus the K-pin.
Oh, you put in a K-pin as well?
Yes, I use the K-pin. The K-pin can go upward or can go lateral. Between premaxilla and the lateral segment, or go inside to the nasal base, the posterior nose, so that they were quite a long K-pin, about 6 centimeters inside the nose.
And you maintain that for
Maintain the K-pin for about
how long?
6 weeks.
6 weeks.
And then remove the K-pin.
Does it emerge through the
No.
node?
You just the K-pin is stay there quite stable. You need to bend the K-pin, the tip into a round one, so that there's no irritation to the oral mucosa.
Okay.
I think I published a case in the Journal of Craniofacial Surgery, just a simple case that has repeated dehiscence, and then the patient was brought from Indonesia to our hospital, and he has multiple repair before, and I think this premaxilla is moving forward and downward, so we do osteotomy, vomer osteotomy, to set back the premaxilla.
Okay, thank you, Professor Low, for your comments. Next, we will go on to our next part of our webinar, which is the Q&A session. And we have 2 questions today for Dr. Lim here. The first one is from Dr. Kenwall, and the question is, what is your experience in doing a lip adhesion for wide bilateral cleft?
No idea. I have no experience in doing lip adhesions.
And then our second question is from Dr. Piercy. The question is there an option for premaxilla reposition orthopedically at a later age, like 5 years or later?
Trying to find that question.
It was posted around 10.
Oh, okay. Pre-orthopedically. So is that surgical or is it with an appliance? I'm not very sure if I understand the question, because it says premaxilla reposition orthopedically at a later age.
Yeah.
So I tend to sounds non-surgical.
Yeah. So Dr. Piercy says not surgically.
I believe there's an option. If the orthodontic colleague is available. I have orthodontic colleagues who are available, and some of them might be interested. A lot of the resource is now put into preparing them for alveolar bone grafts. So with some of this, I believe there's an option at 5 years or older. Maybe Costanza Piazzini may be able to answer that.
Sure. I'd love to. Yes, there's we published a couple of papers on repositioning during the deciduous dentition. That's when it's really easy, because you need very, very light forces. You don't need heavy forces. So if you have, for example, a very vertically protrusive premaxilla, which you can hear me, can't you?
Yes.
Yes, you can.
Okay. What our experience in terms of psychologists is that whilst protrusion in terms of sagittal protrusion of the premaxilla might not be a big problem for the child, a vertical protrusion is a big psychological burden. So like one of my patients was called in class hot dog when she was 5 years old, because that piece of meat sticking out of her mouth looked like a hot dog. So I think there's very much an orthodontic indication, and I would also call it, you can use even just orthodontic wires, but basically what you're doing is you're compressing the suture between the vomer and the premaxilla, and you're lifting slowly by keeping the compression on an area which has just lost control. So you have excessive biologically an excessive addition of bone in the area of the premaxilla, premaxillary bone marine suture. But when you compress it, you just simply have what in the past, like 20 years ago, when we were talking about distraction a lot, there was also a lot of talk about compression. And when you compress a suture, you really reduce the amount of bone, which is what people do with the heads, let's say. So you can do that with the premaxilla, and you can go up to 1 centimeter of reduction, 1 centimeter, 12 millimeters. I've never done more than 14 millimeters of an excessively grown suture. So yes, absolutely. My reply, it's a very long reply for a yes.
Junior, can I comment on the lip adhesion?
Yes, of course,
Yes,
Professor.
there's an audience asked the lip adhesion, and Lay-Hooi said that she does not do lip adhesion. I also do not do lip adhesion because I feel that if there is a wide alveolar cleft and you need to go across the distance and you only do a simple small attachment of lip adhesion, very likely that it will become adhesed. So still suggest the wide dissection and adequate repair under minimal tension. How to judge the lip tension? This is quite rely on experience. However, if you frequently do a lip repair, you certainly will know you just bring the two sides of tissue together, and if they are still tight, you continue to do dissection. Otherwise, maybe you can try Manchester type of repair because there's no muscle repair in the middle. If you do muscle repair, you could have higher tension, but Manchester type of repair do not repair the muscle in the middle. But I do not have experience of Manchester type of repair. Certainly, if you do that, then you do lip revision when the patient grow older. Then you can do definitive bilateral lip repair with muscle reattachment.
Okay. Thank you for all those very, very excellent panel discussions, especially from our presenter, Dr. Lay-Hooi Lim. I think that Professor Lim's pick up this title is really very to close all our panelists the eyes, because this is one of the most debatable and panel the content, and this is really has a unique answer for this question so far, because we have different age of kids, and we are located in different developing or undeveloping countries, so we are not at the same level to have a very full resources. And especially I thank you for our special guest, Maria, and showing in our webinar. So I would like to introduce one of the most important meeting in Europe, because on help of the Europe Flare meeting 2024, Maria will be hosting this Euro cleft, and that's located in Milan. I think, Maria, would you like to advertise? I know it's already be full occupied in the in-persons. You only to give the online seats, right? So yeah, Maria, give us some introduction of this wonderful meeting.
You're a sweetheart. Thank you so much. Yes, unfortunately or fortunately, I don't know, but about 2 months ago, we had to close the in-person registrations because we had, all of a sudden, everything was fully booked. We still have the possibility of people registering hybrid, so following everything and then looking at the registrations as many times as they want, even with a lot of other people if they want. I just don't want to know. But the good thing about it is that loads of amazing friends like Dr. Low is coming and bringing like his very long-term results, and there are going to be 11 plus 10 huge craniofacial centers bringing honestly their data, their long-term data, and comparing them, and without any fear to be dating. So whether you are going to be there or you're not going to be there, but you're going to follow online, I think the most exciting part of the Congress is the honesty with which people are ready to come and tell us what's happened to their kids long term, so that we don't make the same mistakes on our own children. So we're going so soon, but thank you so much. You're always a sweetheart for giving me these few minutes to talk about the Congress. So I hope many of you are coming, and those of you who are not coming, I hope you're going to participate online, and then maybe we'll see each other in another Congress. Thank you.
Yeah, thank you, Maria. And we are all looking forward to this successful meeting. And I think that most of our audience and our participants will join the meeting too. And finally, I have to thank you all, our very important and very wonderful panelists, Dr. Jordan Stenberg and Dr. Dax and Dr. Casey. And I think invited and all our audience to open your screens and please show your smile, because today is a very special day. Yeah, even this title and the topic is not yet to have a very unique answer so far. However, I believe all of our audience can learn a very important class today by Professor Lay-Hooi Lim. Yeah, because Professor Lim present a lot of very good experience cases. Wow, more than 200, 300 cases. Okay, and I will count to 3, and please give me a big smile. Please. 1, 2, cheese. Yeah, thank you for your very invaluable smile. And I have to advertise our next ICC webinar. That will be in 3 weeks later. And the presenter is Dr. Liao. That is the orthodontics in Taiwan National University. And looking forward to this webinar too. And again, thank you, Professor Lim, and thank you, Casey, Jordan, and Dex, and our special guest, Professor Maria. And hope the great Congress in Milan successful and yeah, very, very meaningful for all our participants too. And see you next time, all my friend. Good morning and good evening. Thank you.
Thank you very much. Thank you very much.
Thank you, everyone.
Thank you.
Thank you.
Okay, bye-bye.
Bye-bye.
Thank you. Thank
Bye.
you, Dr. Lim.
Thank you
Bye-bye,
very
Maria.
much.
Thank you so much.
Bye,
Thank
Jordan.
you.
好，我再把那个 paper 搜一搜，然后放在我们的 Facebook 上，因为有一些那个我们的 guest 想要这些 paper。对啊，对啊。好 ，OK，Junior 晚安喽，辛苦了。
明天见，拜拜。
OK，好，拜拜。